I've had medical aid for the longest of time through various medical aid schemes. I've never used one simply because I'm not a sickly person.
They promise too many things, but end of the day, they are not going to give the money for blood tests and some other services, and I'm supposed to pay from my pocket, so I don't feel any use, any point to have a medical aid.
Because the quote, I think it was around about 3,000 rand, and at the time I only had one child, so I was going to cover my child and myself. So I decided to not to proceed with them as it was too costly for me at the time.
I don't have medical aid at the moment. Main reason I'm unemployed, can't afford it as yet.
The advantage is that in case of sickness, in case of maybe accidents and things like that, because normally private hospitals, they need cash, and at that particular time you'll find when you don't have cash, and then you need urgent medical attention and all. So I think that's one of the reasons why it's beneficial to have medical aid.
Currently no problems at all. Quite happy. It's reloaded in January and there's funds available.
I'm happy with my current medical aid and the rates. They are reasonable enough. So I don't have any disputes or whatsoever. I'm fine with them.
So if you're on a medical aid, how well do you understand the benefit structure and how your medical aid generally works? And if you're not on a medical aid, have you considered belonging to one? And which one? There are often many questions about medical schemes, such as, why do medical aid members suddenly run out of funds halfway through the year? Why are people often asked to pay more to pharmacies, doctors, hospitals, over and above what their medical aids will pay? Now, some people may even have questions like, well, why are medical aids so expensive? Why can't I get a discount from my premiums if I have not claimed from my medical aid for more than a year? Why can't I get some of my money back if I haven't claimed from my medical aid? Well, today we focus on medical aids and we'll try and answer all these questions for you. We'll be joined in the studio by the Executive of Clinical Risk for MedShield, the General Manager of Complaints Adjudication from the Council for Medical Schemes, Executive Director, Strategic Advisory Unit at MedScheme, the Head of Benefits and Risk at Board of Healthcare Funders in South Africa. We also have a studio audience, obviously, from a variety of stakeholders, some of whom are medical aid members themselves. Now, you can tweet us at SABC Health Talk or simply interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show ahead. Coming to you after a short break. I'm Dr. Sello Mutaung, and this is Health Talk.
At MedShield Medical Scheme, we don't just talk health, we do health. SMS MedShield to 33023 or talk to your broker to get your kind of care. If we're talking health, then let's talk seriously.
When life takes a different turn.
If I didn't eat the speak, he was going to affect me.
Your will to persevere is ignited.
I'm not a professional speaker, but I'll try my best to give you a word of inspiration.
He was just trying to provide for his family.
If you can't accept it, change it. If you cannot change it, accept it.
And a new story begins.
Made a resolve to myself. I'm learning something new.
Upilong, every Friday at 5:30. Be part of the life-changing journey.
This is your midday report. Good afternoon.
I will be faithful.
I assume as President of the Republic of Kenya.
Let's take a look at how African markets and currencies are performing now.
The central bankers say the success of Bitcoin and other cryptocurrencies is just a bubble.
Breaking stories, detailed economy and sport. Tune into Midday Report every Monday to Friday from 12 p.m.
So what would perhaps change to they say that valuating of people that are sickly, those that are not, premiums should at least be compromised for people like us, because then I was paying 1.8, which I've never used before in my life.
The only thing that I would like to improve with the scheme is the limit. I think they mustn't maybe have a limit. If you are covered, you must be covered in whatever way. The limit must be unlimited.
If they can make them a bit more affordable, especially for people who work, let's say, part-time. But let's say they come up with the lower rates, but then on a sort of longer term basis.
It's overcharging and overcharging by practitioners. And another thing I can prefer is that if they can employ highly skilled staff, not relying on generalized computers, because at some stages when you're having problems, you can send them an email, but you'll receive the same reply, which is computer generalized.
If government can try to maybe open a section whereby they can have or AMA rules by changes so that it can also benefit the poor.
Cut off that excess fee because umuntu angashona because of that 500 rand. I'm not too sure especially by Tatarajan, but then they wanted that 500 rand before I can even go to the theater. You know, then I had to swipe it. If maybe they can negotiate nama pharmacy, you know, how to come up with a solution on that. That will help also. So those two things.
All right, so let's learn more about medical aids from our special guests. Let me start with the lady in the middle, Dr. Lungi Nyati, who is the Executive Director, Strategic Advisory Unit from MedScheme. Welcome to Health Talk, Dr. Nyati.
Thank you so much, Dilla.
All right, and next to Dr. Nyati on her right is Dr. Rajesh Patel, who's Head of Benefit and Risk from the Board of Healthcare Funders in South Africa, or BHF. Welcome to Health Talk.
Thank you.
All right, and of course, the lady closest to me is Tembegile Paswan, who's the General Manager, Complaints Adjudication from CMS, or Council for Medical Scheme. Welcome to Health Talk, Tembegile.
Thanks, Doctor. Thanks for having us.
All right, let's start with you, Dr. Patel. I mean, perhaps just for the benefit of our viewers, we talk about the Board of Healthcare Funders of South Africa. What is BHF?
BHF, or Board of Healthcare Funders of Southern Africa, is a representative body of medical schemes, administrators, and managed care organizations from the broader SADC region. And most of our work, as much as they are our representative member, or we represent them, our work entails about doing what's good for the medical scheme members.
Right. Okay. So obviously there's a variety of medical schemes that you represent. Talking about that then, largely, how many medical schemes do we have in the country at the moment?
There's about 81 medical schemes in the country, ranging from small schemes to the very large schemes that we're aware of in the industry.
Right.
And obviously there are service providers to these medical schemes like administrators and managed healthcare companies, who are the ones that really do the day-to-day work for the medical schemes.
All right, we're going to come back and pose that question to the administrator, MedScheme, but just staying on the medical schemes, we understand that there's different types. You learn about, you hear about open schemes, closed schemes. Just take us through the different types of medical schemes.
Certain large employer bodies have decided to create their own medical scheme to look after the health of their employees and the families of those employees. And those obviously are what we refer to as closed medical schemes. So anyone else from the community cannot join those medical schemes. You have to be an employee of that entity or certain restricted criteria.
Yeah.
So whenever there's restricted membership criteria, those are referred to as closed schemes. Open medical schemes are where anyone in the community or any smallish employer group or what's out there can join that medical scheme. And those are often referred to as open medical schemes.
All right. And then something that sometimes is a bit confusing for people is the so-called gap covers. You know, you see on television every now and then, you know, there's advertisements for some sort of what may sound or look like a medical scheme. What's the difference between these and the proper medical scheme?
There are two types of products. One is medical scheme.
Yeah.
The medical scheme, as described in the Medical Scheme Act, looks to pay your full cost of your health care as it's incurred.
Yeah.
The gap cover or the hospital plan and the cashback plans are what we call insurance plans. They pay based on a certain formula and not necessarily based on the actual costs that are incurred. And that is largely the difference. The hospital plans pay according to like the formula, as we said, could be 1,000 Rand a day or so. Whereas the gap cover specifically relates to anything that is paid by the or should I say, anything the medical scheme pays, and then there's a gap between what the provider might have charged and what the scheme may have covered. That component is what they refer to as the gap, and that is what you often buy gap cover for, to make up for sometimes some of those components that the medical scheme might not end up paying.
Okay. Tamigile, obviously, medical schemes and all of these things that we're talking about can't just, do as they please. There's some sort of regulation. And I believe this is what CMS plays. That's the role that CMS plays. Can you just take us through exactly how you regulate medical schemes?
Okay. At the outset, I need to explain how we establish as Council for Medical Schemes.
Right.
Council for Medical Schemes is a creature of statute. We are established by Medical Schemes Act 191 of 1998. What we do, we regulate the medical schemes industry as a whole. We need to ensure that all the rules of the medical schemes are registered. They are registered with Council for Medical Schemes.
Right.
You imagine that if you belong to a medical scheme, you need to be sure that that particular medical scheme is financially sound. That's also one of our functions, to make sure that the medical scheme that exists or operates in the country are registered as well as they are financially sound.
Yeah.
We also ensure that we protect the interests of beneficiaries at all times.
Yeah.
We investigate and resolve complaints that are raised by members or beneficiaries of medical scheme, and we also advise the Minister of Health in terms of the national health policy.
Right.
So what we do, all medical schemes, they come to us for registration, but to make sure that we also perform a supervisory authority in respect of all medical schemes.
I see. And you recently published a report on medical schemes in general. Just tell us about that. How often do you do that?
We publish a number of publications. I think you're referring to our annual report.
Correct.
What we do on a yearly basis, we need to inform the industry, that is the medical scheme, the brokerage companies, administrators, managed healthcare organization, as to how they've performed in the previous financial year. So we consolidate all that information data, and then we inform them as to how they performed in the previous year.
Okay.
So what we look at, how they performed previously to what they do now. If there are any corrective measures or any interventions that are required, which we would have discussed those with the medical schemes anyway prior, or administrators, we disclose that as well.
Okay, we're going to come back to this issue of performance of medical schemes over time. But let's invite a comment from Dr. Nyati. You represent a medical aid administrator.
Correct.
Just explain to us what the role of an administrator is. Oftentimes, people can't make out the difference between a medical aid and a medical aid administrator. Can you just make it simple for our viewers?
Sure. So medical aids have to perform functions like collect your contributions, pay the claims, put together their rules, make sure that they're financially sound, as Ma'am has said. Often they outsource that work to administrators, and administrators then perform those functions. So an administrator specifically is the one that collects contributions and pays claims, collects the debt that relates to it, and often they man a member call center on behalf of the scheme. There's also a managed care provider, which then comes up with some of the formularies, and their role is to try and limit the risk exposure of the scheme. So ensures that the money that's collected is used to the best of the ability for the people who have paid it.
All right. Let's look back at, she mentioned how medical aids perform and so on. And generally, we say that we have about 82 medical schemes currently. Perhaps the first question that we need to answer is, looking back over the years, what percentage of the population are covered by medical schemes? Anyone can
So about 16%. 16% of the South African population is covered on medical schemes.
Yeah. And why is that? Why can we not have more?
I think there's a couple of reasons for that. The one is the price of the benefits that are on offer, and that is what we refer to as the contribution or the premium. It's been going up quite steadily, in fact, above inflation. So even though your salary goes up 5 or 6%, the inflation for the medical scheme contribution is going up by 3 to 4% above that. And often what happens is that obviously it has an impact on your disposable income eventually. And some people cannot afford to continue to be on the medical scheme. And yes, if you try to attract new people onto the medical scheme, they must be able to afford those premiums. And I think that's becoming a hurdle. One of the critical components that does drive those high costs at the moment is the prescribed minimum benefits. And the price of that prescribed minimum benefit is just increasing quite significantly. And that's making it more and more unaffordable.
Okay. So what are these prescribed minimum benefits, and how do they come about?
Prescribed minimum benefits are, it's 270 diagnostic and treatment pairs that are listed in Annexure A of the Regulation of the Medical Schemes Act, and there are also limitations that are also specified. Together with that, there are a number of chronic diseases that are also listed. There are 25 or so. What happens is that when those regulations were enacted, we had to ensure that members of the medical schemes are protected at all times so that they are not a burden to the state, because previously what will happen, medical schemes will impose limit in respect of your benefits. It means that if you've overutilized or you've reached the limit, then you'll be dumped at the state. So they were introduced in order to protect you and I as a member of medical schemes, that should you be diagnosed with one of the conditions that are listed, there's that statutory protection that ensures that the medical schemes cover those costs in full, whereby you're not supposed to pay any money from your pocket, though there are exceptions, meaning that there are rules that you need to play by. You need to go to a designated service provider. If it's medication, you need to make sure that you use a formulary drug that is listed in the rules of the medical scheme. But in a nutshell, they were there to protect the members of medical scheme so that they don't lose cover in the instance that there are serious medical conditions that you require treatment for.
We're going to go back into greater detail on the DSPs and so on. But just in the last 30 seconds, Dr. Nyati, looking at performance of financial stability of some of the medical, there's a notion that the smaller schemes have struggled to survive over the years. What has been your experience?
I suppose it's different for different medical schemes, and there are different reasons why some schemes survive and some don't. Perhaps I start by saying the majority of schemes collect their contributions and they have to pay claims. If you look at the history of the medical schemes in general, if you look at the reports that CMS provides, in 2016, 92% of contributions are paid towards claims. And so medical members are actually claiming a lot from medical schemes. If those claims exceed the amount of contributions that are collected, and there are no longer any reserves for a medical scheme to be able to pay those claims, then a scheme finds itself in trouble. The Council of Medical Schemes tries to protect all of those schemes by having a minimum amount that needs to be kept in reserve for situations such as that. But different schemes end up not either having that reserve or just incurring too many claims. And smaller schemes, because the members are fewer, if you have a big claim of 1 million rand, for example, for one member, it could wipe out a lot because there are not many to pool their money.
Yeah. All right. Perhaps let's go for a quick break. When we come back, we'll continue our discussion on medical aids, and this time focusing on the benefits. Please stay with us.
Medfield Medical Scheme, we don't just talk health, we do health.
It's so good, nothing else can replace just your slightest embrace. And if you only would be my own for the rest of my days, I will whisper this phrase, my darling, c'est bon.
If we're talking health, then let's talk seriously.
Okay, welcome back. We're talking medical aids with our special guests. In the middle, Dr. Lunginyati, Executive Director, Strategic Advisory Unit from MedScheme. And the lady closest to me is Tembegile Paswani, who's Head of Claims Adjudication from CMS, or Council for Medical Schemes. And we're now joined by Rosalind Reddy. Rosalind is Executive Clinical Risk from MedShield Medical Aid. Welcome to Health Talk, Rosalind.
Thank you.
All right, maybe let's stay with you. We're talking about the benefit structure of medical aids. Just how are these benefits put together?
Okay, so benefits in general are governed by legislation. So the fundamental is the application of the Medical Schemes Act, and that is the basis on which medical aids will start to build benefits. We take into consideration that with respect to PMBs, prescribed minimum benefits, we also spend a lot of time just understanding what members require, both from a perspective of health and their wellness. And we also spend a lot of time in market research, understanding competition in the environment, so from one medical scheme to the other, but also just looking at local and international benefit structures and apply that. We provide benefits both in and out of hospital. So your out of hospital would be things like your medical savings or your day-to-day benefits. And your in-hospital would be providing extensive in-hospital benefits to make sure that members have got comprehensive cover.
And how easy is it to understand all of these benefits, basically?
So I think in general, when a medical scheme puts together benefits, we try as much as possible to make it quite simple. In order for members to understand their benefits, but also for brokers to be able to utilize the information and share that with their members for them to get a common understanding. But I think what has happened over the years, in order for us to remain competitive out there, there's been lots of announcements and nuances made to your basic benefit structures. And as a result, medical schemes have been forced to become very innovative around benefit design. And I think that is what has made it complicated over a period of time.
So perhaps from a council's point of view, I mean, there's various options, many different medical aids have different options, and there's different benefit structures depending on the option that you are on. From a regulatory point of view, what is it that you prescribe?
We don't prescribe the number of options and what should be contained in that. It depends on the option itself, right? If the actuaries or the medical scheme itself indicate to the registrar's office that these are the benefits that we would like to offer to our members, considering the contributions as well, what we review as an office, we check whether is that amount of contribution compared to the benefits that is offered. Are they fair to members who will be belonging to that particular option or medical scheme? But what we are concerned about as the regulator is that the options are way too many. For one medical scheme, we know some medical schemes have got like 12, 15 benefit options under one, and that makes it difficult for members or consumers out there or applicants to choose or to select from one benefit option to another.
Them, isn't that so?
We approve them, yes, granted. But what we've informed the medical schemes as well as administrators is that moving forward, there must be a change in the game. They need to consolidate. We've issued publications, and there's also ongoing consultation with the industry to indicate that moving forward, we can't be having so many medical schemes. We must get to a point where any person who wants to join a medical scheme can make a choice, because it must be easy. They must be understandable as well, so that they make a choice that will benefit them at the end of the day. So they are aware of our pronouncements in respect of these many options that are available per medical schemes.
You wanted to add something?
I did. Yeah. The world's changed a lot, Silo. Before, you could have single packages that cater for the majority of people, and people can move around in that. But people, consumers should I say, have become very specified. Some people want more optometry benefits, some have older dependents on them, so they are concerned about the chronic benefits of their mom or dad. Some just want hospital cover. There are those with children that want to be able to see psychologists and all kinds of things. And so part of what's added to the complexity is that in trying to cater for the many members that are now joining schemes, we have had to look at the different utilization packages and try to group benefits as best we can while making a single option sustainable. There's a rule also by medical schemes that the Medical Schemes Act that each option must be sustainable in and of itself. So if, for example, you've got an option that has a lot of chronic benefits and older people, for example, tend to use that benefit option, they're likely to use more benefits in that option because typically they've got more chronic diseases. But then it means that option ends up having to be too expensive. And so you want to balance all of those things: income, age, chronic diseases, utilize how people use their benefits to make that. And that's just added to the complexity.
It's interesting you mentioned, differences in obviously options and particularly low contribution options, the fact that they need to be sustainable. But what has been the practice over time?
With low contribution options specifically? Well, again, let's talk about this balancing act, right? People want to pay lower contributions, but they typically also want to claim for everything. And so the balance that one has to strike is that in making that option sustainable, one has to make sure that the contributions that are paid by everybody and the claims that are incurred balance out. And so part of what's happened over time then with the lower contribution options is you limit the choice. So you try and have negotiations with specific providers and hospitals about how they can claim, how much they can claim, how varied they can claim, to try keep that claiming pattern as sustainable as possible. And more schemes actually are starting to have lower contribution options so that more people can have access to the market, to your question earlier about why are so few people on medical aids. And we'll talk about PMBs, I guess, at some point, but we can talk about the impact of that.
That's right, Let's get, obviously, this is the area, perhaps, if you like, that's least understood. We're not sure whether it's deliberate or not deliberate, but oftentimes people that are on, at least this is what, some of the providers would tell you, that members that are on low contribution options tend to demand more than what they have. What's been your experience at Medfield?
With respect to low contribution options, I think one of the fundamental flaws is selecting those members to access low-cost options. So it's basically matching, what does a member require versus the benefits that the scheme is able to provide for a low-cost option. And when that mismatch exists from the beginning, it becomes very, very difficult to give the member what they require, because there is a mismatch between what they believe they have access to and in reality what is available. And a large portion of this has to do with we have brokers, which we consider our intermediaries to a greater extent, that would be selling these low-cost options to members. And there has to be a lot of education around our member accesses this benefit. But I think the big thing around this is education. There has to be a lot of education at every point of contact with a member. Whenever they try to access a benefit, whether it's in hospital, whether it's out of hospital, you have to continue to educate them.
Okay, let's spend the last 2 minutes talking about the medical savings account. Can somebody just explain what that is? And is it somebody's money? Can people just claim it? Do you want to just give us the...
So basically, the medical savings option is a choice. So normally a medical scheme will have multiple options, and some of the options will have a component of medical savings. The savings component is legislated by the Medical Schemes Act, and there is a percentage of your gross contributions that a member can put away towards their savings, and there's a maximum of 25%. And that then is used for a member to access that money and pay, medical benefits or healthcare benefits in an out-of-hospital environment. They're not obviously allowed to use that money to pay towards their contributions, and there are some rules around how and when they can use it. So if there are specific exclusions, that would apply. But in essence, that is a member's money, and the member can utilize those benefits. One of the rules around that, as far as the Medical Schemes Act is concerned, is that we should not be paying prescribed minimum benefits from savings.
Right. And then there's the notion that, funds run out. Perhaps you might want to explain the difference between things that are paid out of the day-to-day benefit versus, the total risk.
Okay, so if one reads their scheme rules, typically in the day-to-day benefits, so these are typically out-of-hospital benefits that you can use day-to-day for your medical needs. And most of those benefits have limits that are attached to them. So they'll say, for example, for dental, you only have a benefit of 5,000 Rand per family, some per person, per year, per 2 years, per 3 years. So those are typically day-to-day benefits that govern the kind of care that you require out of hospital. Most of the time, out of hospital cover is usually unlimited or typically has a bigger amount that's allocated to it. But most of the time it's unlimited. And usually that's called risk benefits. And in risk, everyone pools their money together, everyone in the scheme pools their money together and are able to use some of that depending on what they need. So in 1 year, you'll have a member that's pooled their money, and that year they need no hospitalization. But the risk is that there may be somebody else who goes into hospital after a car accident and has to incur 4 million Rand. And so that's the risk pool.
We're going to, in the next segment, obviously, we're going to talk a lot more about how people then use these benefits. And by the way, Thembekile Paswane, thank you so much for your time. You're not lost to us. You're still part of us as part of the studio. But we may come back to you with a question or two. All right, time for another quick break. When we come back, we now talk about using your medical aid. Please stay with us.
It's so good, nothing else can replace just your slightest embrace. And if you only would be my own for the rest of my days, I will whisper this phrase, my darling, c'est bon.
At MedShield Medical Scheme, we don't just talk health, we do health. MedShield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well.
Welcome back, and thank you so much for staying with us. We're still with our guest, Dr. Rajesh Patel from BHF, Dr. Lunginyati from MedScheme, and Rosalind Reddy, from MedShield. Correct, yes. And of course, we have a studio audience, and I'm told that there's a question or two. Can we get the questions one after the other, please? Yeah. Please state who you are, where you come from, and your question.
My name is Nokanyi Somulomo. I'm from Council for Medical Schemes, a customer care manager. To MedShield, I heard talking about member education. I just want to find out, to what extent does a medical aid scheme does member education? Do you have sort of forums for members to do member education? Or do you do it through your call centers? Or do you have any material that you distribute in what languages or in different languages?
Excellent
Thank
question.
you.
Let's take the next question.
Okay, what I want to know is why is it difficult to understand medical aid? My name is Xoliso.
Xoliso.
Yes.
Okay. Any other question? That's it. Okay. So, questions are directed at Madshield.
Okay. So, to answer the question on educating our members, so there are various modalities that we utilize to educate members. We do send out written communication to members during the course of the year. At the end of the year, we would normally send out communication around new benefit design for the following year. We also send out quarterly newsletters identifying certain areas of focus to educate our members on. We also utilize our broker fraternity quite largely, because they contract with the member. So we have forums for them where we actually call them in, we provide learning material, and we educate them on the product, and then they are able to then pass that information on to the member. We also, at points of contact with the member, be it through our website, be it through the call center, be it through client liaison offices that go to large pay points, we utilize them as well to pass information on to members and to subsidiaries.
Okay. The other question, perhaps one of you can take.
I can take
why is it so difficult to choose between options?
I think the important thing to realize is there's thousands of different clinical diagnoses, there's thousands of different kinds of investigations that can be done, and various different ways of treating medicines, procedures, therapy, counseling, etc., for the various type of conditions. And this essentially becomes very complex for the general public. And what we talk often about infinite needs and finite resources. So this is where the medical scheme has to now narrow it down so that with all these various permutations and possibilities, you try and stretch that range so that as many people on the medical scheme can be covered as generously as possible. And that's where the complexity comes in, because someone has to look at the benefits out there and decide how can we generally cover for the limited amount. And you talked about the different type of options and the different pricing, etc., to get the best result with this limited amount of money. And unfortunately, not everyone is health trained. And there's the whole issue of money and money allocation and pricing that comes into it. So it becomes very, very complex for everybody. But there is a solution. And we talked a little bit of the education, but there are brokers out there in the industry who do understand the complexity of the design and who understand often the members' needs. And they can try to pair the best option and the best benefits for those members and their needs.
Okay.
It's not going to cover everything that you might think that you need.
All right. Let's come back to Dr. Nyati. Now, talking about limited benefits, low contribution options, and what have you, I mean, it then suggests that there has to be some tight management of this. And this is where you hear things like designated service providers. Just take us through that concept.
So like I said a little bit earlier in the show, one of the things that's important is the ability to negotiate with doctors or hospitals or other kinds of healthcare professionals. And typically, some providers charge rates that are that could be higher than what a medical scheme would typically cover according to their benefits. So what a designated service provider is either a group of providers or a hospital group or a network of doctors who have agreed with the medical scheme that they will charge rates that fall within what the medical scheme would cover. And so then the medical scheme will then say, for such conditions or under such circumstances, would you please go and see this doctor, to ensure that you are protected, actually, especially that you don't have to pay out of pocket. Medical schemes go out of their way to ensure that their designated service providers are wide enough that members can go to them without being inconvenienced.
I'm going to ask you about what regulations say about negotiating tariffs. Who do you negotiate with? But I believe there's a question from the audience. Yeah.
Yes, my name is Matsi Mshani. I'm from Council for Medical Schemes, and I'm the Education and Training Manager. My question is just a follow-up on the question that my colleague posed to Mitchell. The question is, what do schemes do to ensure that the technical jargon that is used in medical scheme rules are accessible in languages that the members understand best?
Okay, short and crisp.
So just answering that question, currently MedShield only produces its documents in English. We are looking at other languages. What we do is interpreting the rules of the medical scheme is obviously critical to a member and their understanding of their entitlement. So what we do on an annual basis is we produce a comprehensive member guide where we try and actually remove medical jargon to a large degree and try and simplify the wording so that the members are able to understand the information, and the benefit guide is quite comprehensive. I think further to that is members are always welcome to contact us. You know, we have our call centers that are open to assist members, so if there is if there's a misunderstanding of a particular benefit, they are welcome to contact us so that we can explain the information.
On a scale of 0 to 10, how satisfied are you that your membership understands these things?
I think this is an area that is quite complex. I think Rajesh alluded to this. The medical schemes environment in itself and the application of the Medical Schemes Act, it's quite complex. So I think on a scale of 1 to 10, I would probably say maybe around 4. I think we still have a lot of work to do in this area. And I think as medical schemes, we need to take those reins and really try and get down and understand, what members actually do understand and, what can we do further to assist them on this.
Okay. Let's get back to you on that issue of DSPs. One related issue, of course, I still need you to answer the issue around negotiation of tariffs, but that very quickly. Then there's a concept of people having to make co-payments, and some people don't understand this, some people do not like it. Just take us through this concept.
I'd imagine then people don't like it. Nobody likes to pay more again after, but
especially if they know that they are on a medical aid.
Yeah,
so
sure.
Think everything should be paid.
Yeah, sure. And it probably links a little bit to the question about member education. Sure. But there are several circumstances where you can expect co-payments if you haven't followed rules or you haven't understood your rules. The one is what we have talked about now, the use of designated service providers. So if the option you're on says that for hip replacements, for example, you need to go to X provider, and you do not go to X provider, you then may incur co-payment. If the scheme doesn't allow it at all, then it won't be covered. Or if that provider charges more than what the scheme would pay, you'd probably have a co-payment. So it's important to know for the kinds of conditions you may have to see whether there are any additional things that you need to consider. The other reason is formularies. We spoke about formularies for medicines. So it's important to also have a conversation with your provider when they're prescribing medication to you to talk about whether or not they are following their options formulary. Most of those formularies are available in provider websites, and some schemes have gone out of their way to ensure that doctors and the pharmacies have access to those formularies to ensure that you don't get medication that's outside of a designed formulary. So typically it's those two areas where there are co-payments if you go to a provider that's outside of the network or the DSP, or if you're using medication that's out of the formulary, or you're accessing services that are not covered at all by the scheme. Cosmetic surgery, for example, is one of those kinds of conditions.
So member education is still crucial, even in terms of responsible use of medical schemes.
And I think it's important for members to spend the time learning about their medical schemes rules, especially for the conditions that they have. And I think people with chronic conditions probably are the ones that are often susceptible to having co-payments because they have to receive care again and again and again.
Okay, all right. Let's just hold it there because we need to go for a quick break. When we come back, we continue our discussion on, well, how some people use, but some people misuse their medical aids. Please stay with us.
MedShield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well. MedShield, embracing our members in good health since 1968.
A lot of us rely on tech to survive, and Africa is already a mobile-first continent.
We built mobile technology that connects motorcycle taxis to commuters and businesses in real time.
My phone was the most important thing.
Africans are using technology to innovate. On Network, we have African technology and social media news. Even robots have heard about us.
Hello, watch Network on SABC.
For African technology and social media news, join Ms. Phumelele Zondi on Network every Sunday at 9 p.m.
Okay, welcome back. We're discussing medical aids and how people use their medical aids, responsible use of medical aids. Now we're going to be focusing on fraud, waste and abuse in the medical aid sector. We have with us in the middle Dr. Lungi Nyati from MedScheme, closest to me Dr. Rajesh Patel from BHF, and of course Rosalind Reddy from MedShield. And of course we still have our audio studio audience, and I believe there's one or two more questions. Let's take the last few questions. Yeah.
I'm Mamazane Maduna. I am a medical advisor for Council for Medical Schemes, and I sit within the clinical unit for CMS. So now I want to go back to what Dr. Nyati mentioned in terms of formularies that medical schemes use in terms of providing care to their patients. In the same breath that we're saying that medical schemes should provide awareness for their members that join the schemes, I'd like to know now, how do we then make sure that the clinicians, the practitioners that are indeed the ones that prescribe medicines to medical aid schemes members are made aware of what one is available within a scheme's formulary and protocols? So how do we make sure that myself as a clinician know which protocols I should follow for a particular patient that belongs to a certain medical scheme?
All right.
And protocols in the same way?
Okay, do we have the last question or comment from...
Just the last comment on the member education. I think schemes should take it into their consideration, the member education, because it's very crucial. It doesn't matter how you can redesign your benefits, but if your members do not understand them, nothing is going to happen. Okay. There are shocking queries that are coming through to the regulator that should have been resolved at the scheme level, or the information is residing with the scheme, but we find that members, when they call the scheme, they don't get this information. They resort to go to the council. It is the scheme's responsibility to break down the benefits to the members and teach the members and in languages that the members could understand.
All right, thank you so much. Let's start with Dr. Nyati.
So briefly on formularies. Formularies are a type of protocol, and most providers are given access to formularies, especially those who are on scheme networks. Most schemes are give their network providers guides on for the schemes that we are looking after. These are the formularies that apply. Most formularies are also available on websites, and we're trying to actually now link some formularies to doctors' practice management software to make it even easier for doctors. But there's a lot of work that has been done to try and make sure that that kind of information is available to a doctor before they see a patient.
Okay. Dr. Patel, I mean, there's lots of talk around member education. And it seems that, the expectation is that the medical schemes themselves should do everything possible to ensure that the members understand. But surely the members have some role to play in understanding their own benefits. Your comment on that?
Absolutely. In fact, all of us that are involved in this environment have a role to play. So even an organization like the Board of Healthcare Funders, the Council for Medical Schemes, government, employers, everybody who's involved, even the service providers, have an obligation as much as possible to communicate to members, to make them understand this very complex environment in which we operate. And there's no doubt about that. Well, I think what is missing to the members out there is when they have a problem, often they don't know what to do next. And I think it's important that they understand that there's different routes that you can go to have your problem sorted out. We mentioned earlier there's administrators. And yes, when you deal with the administrators, internally within the administration, there are appeal processes. If that fails, you must go to the scheme and the scheme management. Within that environment, there are certain appeal processes in place. When that fails, it can go up to the scheme's trustees, and they have certain processes in place there to evaluate complaints. And if all of that fails, definitely there's the fallback on the council. And within council, there are a couple of steps that go through appeal processes. And often what happens is that members are not aware of these escalation processes or what's available to them. And I think this type of forum itself becomes an opportunity to explain these processes to members, that they do have their rights, they do have all these appeal processes, and it's important for them to become aware of that.
All right, let's then come back to what we want to talk about in this segment, and that is fraud, waste, and abuse. Perhaps I'll stick with you. If we could just explain to us what the difference is between fraud and waste, and how serious this problem is.
Fraud is deliberate misrepresentation of an event that's occurred. For example, a prescription is written for medicine, but then you get milk products or toiletries, etc., for those type of things. That is deliberate misrepresentation, and it's fraud. Waste and abuse is unnecessary care or overutilizing what is actually needed for that type of care. An example of this is what we've seen in data analysis of 6.8 billion lives, is the sleeping pills that are prescribed to approximately 5% of that population. But when we see the overprescription, as in how many of these people get at least 30 tablets at a time, we find it's 5% as well. So what that indicates is whenever people are prescribed sleeping pills, which is supposed to use for short duration, is actually being prescribed and given out for 30 days. And this is something that can lead to addiction, etc., and problematic in that way. That's an example of waste. Another one where there's overutilization is in the newborns. Newborns, very sensitive, very emotional. The low birth weight babies is in the region of about 4%. But what we have found in the medical scheme and environment is approximately 13 to 40% of the newborns actually being put into neonatal ICU. And then, you notice this discrepancy that between the health need versus what is actually taking place out there, it's a big gap. And the question needs to be asked, are each of those neonatal ICU admissions absolutely necessary?
All right.
And that's what results in cost driving.
Okay. Dr. Nati, there's been obviously an increase in the sale of these so-called hospital cashback plans, and there's been lots of fraud associated with this. Do you want to perhaps just take us through your experience, or at least your understanding in terms of what this is?
In 2016, most of the medical schemes in our stable struggled with the claims. We saw unprecedented claims. Actually, in many schemes in the industry, we saw unprecedented claims, and so we had to dig and look at what was going on. We got some tip-offs about areas where some teachers at that time were speaking about how during school holidays they're able to make a lot of money because they just go into hospital and they get a lot of money from hospital cashback plans. So we did many investigations about it, and we are finding that there are some syndicates that exist between members and doctors, and some of them even with hospitals, where people who have cashback plans deliberately stay in hospital for longer than they need to so that they can get money from hospital cashback plans. And so as an industry, we've put an eye on this, and we're investigating it. We've actually even had some collaborations with the hospital cashback plan insurers to find cases where there's abuse linked to this, and which doctors, there are doctors that are on our watch lists, there are hospitals that are on watch lists, because we are finding that there's abuse of healthcare services in order to get money from hospital cashback plans, and that's fraud.
It's quite a serious problem.
It's a very serious problem, and it's important for us to speak about it and to weed it out, and for people to know that we are actually concerned and we're looking.
President, what's been your experience in terms of, fraud? I suppose there's many examples with MedShield.
With MedShield specifically, we spend a lot of time and effort trying to get to grips with understanding, your normal claims processes and understanding outliers. We spend a lot of time on, programs that we utilize to understand, where there's sudden escalations in claims, in particular with particular members in particular regions. We also have programs where we go out and we then use those findings and we interview both providers and members to get an understanding of why has this suddenly occurred. And we do have instances where providers do acknowledge that, there is a possible overutilization or some possible fraud that went on, and they normally then sign documents with us to then pay back the money. But, it accounts for a huge percentage of what we pay out as claims. And, obviously at the end of the day, this gets passed on to members in their contribution increases for the next year. So you may be having, as a member, short-term benefit of a cashback plan. But at the end of the day, you are paying in your contribution for the following year. So I think it's all about education, but I think it's all about holding people accountable when fraud, waste and abuse does occur.
I think, you know what, because we've run out of time, this is such an important topic, and I'm sure that we're going to dedicate next time, anytime soon, a whole show just dedicated to fraud, waste and abuse. Well, ladies and gentlemen, thank you so much for your time. It's been really, really insightful. Of course, thank you so much as well to our studio audience, and to you folk at home, thank you so much for being with us. And unfortunately, that's all we have for you for today. We're back on your screens again in next week, same time. And remember that if you've missed any of our previous shows, you can always download them on YouTube. I'm Dr. Sello Mutdeung, and until next time, do take care.